Good morning, everybody. We will start with this session, which is entitled The Power of Data in Pharmacy, Supporting Surveillance of Infection Outbreaks and Identifying High-Risk Patients. I'm Raj Vaidya from India. I'm going to chair this session today. I'm a community pharmacist and also have been a member of the community pharmacy section of FIP. It's a brief overview of the program today. We have 2 speakers, and that will be followed by a panel discussion. Now, we would like to record the attendance today. So those of you who would like to volunteer to be recorded, there are volunteers around who will move around and scan your badges. So that will help us to record the attendance for this session. Some logistics before we move on. The speakers have declared that they have no conflicts of interest to report. You must have already downloaded the Congress app. We request you to please evaluate the session at the end of the session, so that would help us to prepare better next time for the subsequent sessions in the Congresses. It's very easy to download this app. At the end of both the sessions, you're all welcome to ask your questions in the Q&A part of the program, which is going to be the panel discussion. And you can use the yes or no page on the Congress booklet in case there are some questions or yes and no asked by any of the speakers during their presentations. Something important about the PowerPoint slides, we would like to remind you that please do not record any of these sessions. Only the FIP authorized staff are permitted to do that. Please do not come forward to request to download the speaker slides at the end of the session, because these slides will be uploaded, of course, subject to the speaker's permission, on the FIP website and post 1st of October. And you will be getting the link to upload them in your email. Please do publicize the FIP Congress and by using the hashtags FIP Congress or hashtag FIP 2023. A gentle request, please shut off your mobile phones or put them on silent mode and put off the vibrations as well. Just a reminder, when you leave the room at the end of the session, please take all your belongings with you. Do visit the FIP booth and learn about FIP and its various programs in the exhibition hall. Now, those of you who belong to the following associations are eligible for getting CPD credits. So any of you from these, please, you can mark your attendance. The sessions code for this continuing professional development program is 2167. Please record the CPD code on the session page in the Congress app. So this will help you when you go back to claim your CPD credits from your respective organization. Happy World Pharmacist Day to all of you, and we look forward to a pleasant Congress with all of you. So we would like to begin with the session. And first with us we have Dr. Sagung Savitri. She is a senior lecturer at the Department of Public Health, Faculty of Medicine, University of Udayana, Bali, Indonesia. She is a medical doctor by profession and has done her master's and doctoral in public health. Please join hands to welcome Dr. Savitri. Please.
ladies and gentlemen, and the esteemed colleagues and distinguished guests. Good morning, and thank you for joining us in this session. It is really an honor for me to stand before such a diverse and accomplished audience. And thank you very much for Mrs. Raj Vidya for introducing me in the session. I just want to add an acknowledge to my colleague, Dr. Lila Wulandari, as she is the first author of this article. So the purpose of the purpose of our gathering today is to delve into possibility of using the pharmacy surveillance data as a syndromic surveillance in response to the outbreak. But first, I want to acknowledge that all authors of the articles have no conflict of interest. So we consider why we consider that the topic is important. It's because we live in the era where there are unprecedented change and interconnectedness between all of us. So this situation make the outbreak even can possibly arise. So it is important to find a surveillance method as an early detection method that can anticipate the outbreak. So over the next 25 minutes, I will present a structure, exploration of pharmacy sales data for surveillance. I will start with the background of the idea, the potency of pharmacy on syndromic surveillance, and then move on the Indonesian context and the way forward, and then end it with the conclusion. So since year 2000, in the year 2020, Indonesia has faced an immense challenge in combating the COVID-19 pandemic with a staggering number of confirmed cases and deaths. That's make Indonesia as placed as the second number of country with confirmed cases and death in among ASEAN countries. So the pandemic itself has left high impact on Indonesia economic, social, and healthcare. The economy took a severe hit as lockdown and restriction disrupted business and livelihood. Moreover, the healthcare system faced unprecedented strain with hospital overwhelmed and healthcare workers working tirelessly to save lives. Indeed, before the COVID-19 pandemic, Indonesia has several persistent problems related to infectious disease. So this condition is exacerbated by the obstacles bearing on human and infrastructure resources. So limited of human resources and unequal distribution across country significantly become challenges to deal with any disease outbreak. Therefore, when the pandemic hit Indonesia, the health system was overwhelmed, evident by the healthcare system struggle to cope with the surge of COVID-19 cases. In previous experience, Indonesia has experience of several outbreaks. For example, SARS in 2003, influenza H1N1 in 2009, avian influenza in human in 2005 to 2012. However, there are still a lack of an adequate number and an unequal distribution of human and infrastructure resources that make we are overwhelmed to overcome the pandemic. And also, we have in Indonesia, we have a vast and diverse geographic area, also tropical climate within very dense population and high mobility that mix up together, make the area of Indonesia become more vulnerable to the outbreak. It's just to remind us that health surveillance is a systematic and ongoing process of monitoring, collecting, analyzing, and interpreting health-related data to assess the health status, detect health trends, and identify potential health threats within population or specific community. So health surveillance has been the core of public health. But among many types of the surveillance, we have one which is also important, is a syndromic surveillance. So the syndromic surveillance detect individual and population health indicators before the diagnosis confirmed. So it tracks behavioral patterns, symptoms, signs, and laboratory findings that can supplement a traditional surveillance based on routinely data that is recorded and reported. So the syndromic surveillance leverages data on the syndrome indicative of particular disease from any health facilities, which may exhibit signs of an onward trend in such disease. For example, an increasing visits to emergency units, primary healthcare facilities, or hospitals for influenza-like symptoms. Another example is absenteeism in school or workplace due to influenza-like illness, or influenza-related medication purchasing behavior at pharmacies that is increased, that can indicate the cases of influenza in the community may already rise. So, we search the potency of pharmacies as a syndromic surveillance in other countries. For example, studies by FIP et al. In 2014 that show the correlation between medication sales data and the reference data for disease outbreak. For example, the increasing increase from medical records, microbiological laboratory data, hospital admission and discharge, and clinical emergency department. That's also show an increase of cases. In other area, Mukal et al. In 2015 also show the correlation of sales of over-the-counter respiratory product with the laboratory pathogen detection. And he also showed that the antiviral prescription for influenza is also increased and matched with the onset date and also in line with the size of the incidence of influenza. Other study by Patwardhan also show the correlation between prescription sales data from a large US drug with the Google Flu Trends surveillance system. And the other studies also show the correlation between the pharmacy sales data within the increase of cases of influenza. So these studies actually collectively demonstrate that medication sales data from pharmacies can serve as a reliable and timely source for information for syndromic surveillance. Even in pandemic situation, there are some studies show the role of pharmacy. For example, in China, where pharmacy has served to report the first cases of COVID-19. Other studies also show that pharmacies can also monitor and resolving drug shortage and can also help reaching clients need medication in remote area, and also can help to educate the community as well as involve in clinical trial to find the effective medication during the pandemic, the COVID-19 pandemic. So that's our search from other country. But what about in Indonesia? We try to see the surveillance and the pharmacies in Indonesia. So in Indonesia, we already have at least 3 syndromic surveillance. First is based on the data that routinely collected from community health clinic known as the Puskesmas. So from this data, we can estimate the prevalence and the distribution of many kinds of diseases in the community level. The other surveillance system available is EWARS, or the Early Warning Outbreak Recognition System, that is based in the selected hospitals. So this hospital will report at least 29 diseases related to that is potentially to become outbreak that they found among the patients. Another is the Sentinel surveillance report, which came from the Puskesmas and also from the hospital. For example, in the Puskesmas level, they are required to report an influenza-like illness, while in the hospital, they are required to report the severe acute respiratory infection. However, one weakness of using the Puskesmas data or community health clinics data because it's not comprehensively capture the behavior related the health seeking among the community. Because some study has find out that There are around 20 to 30% people prefer to have a self-medication or going to pharmacies to buy some medications without looking for formal medical care. That is why, so this gap can lead to substantial underestimation of the disease burden, which is this will lead to the what we cannot detect the potency of outbreak which will be coming. But on the other hand, we can use this preference behavior to the pharmacies to be included in our surveillance system. While about the pharmacies in Indonesia, there are a lot of pharmacies over the countries, and they can be accessed in more convenient hour because they usually open 15 hours per day, 7 days a week, and they don't need to have a long queue. And in 2009, the community pharmacies recognizing as a primary point of healthcare based on the Pharmacy Practice Act in 2009. And in 2014, pharmacies also being recognized as a primary care network under the National Health Insurance Scheme, or GKN, in 2014. And in 2016, the pharmacies also determine their rule by the regulation of a standard of service in community pharmacies. Thus, pharmacies in Indonesia are not just a place to obtain medication, but they have an expanding roles in the primary care in Indonesia. Pharmacy this can be seen to be a promising avenue, completing available surveillance method. However, integrating pharmacies into our surveillance system need several considerations, because we must establish a systematic and ongoing data collection where it should allow pharmacies to record and report medication sales data routinely. And because we also need not only to report the types and quantities of the medication, but this report need other prescription-related details which can be used to detect the outbreak. And also, we have to make a collaboration with stakeholders to ensure that the system will be accepted and will be run by all the stakeholders. Involvement of experts such as academic groups and clinical information system vendors also important to make the syndromic surveillance system with a high sensitivity and also with a low cost. And this development of surveillance need to be led by the Ministry of Health as well as provincial and district health office. And also, the development of the surveillance systems need to involve end-user involvement, like the pharmacy staff, because the pharmacy staff will ensure that the system will in line with the practical and relevant to their daily operations. Data compliance is still a problem in some previous surveillance. That is why we need to ensure if we develop the system, then we must make a simple system, yeah, and user-friendly, so those who need to enter the data or need to collect the data will accept the system and willing to enter the data regularly. Another consideration is collaboration and partnership with other programs, for example, like antimicrobial resistant task force, yeah. And also we must have a look the existing system such as SIPNAP and SIMBOK, which is a requirement to report medication related to narcotics. And then we have to consider also the technical challenges usually happen in the infrastructure, hardware, or internet coverage. And also, we have to think about the timelines and specificity of information. So there are also studies to report that usually the surveillance is not timelines. So there are, for example, today is the sign or symptoms, but the report have, for example, 5 to 7 days before it being reported. So in the surveillance system, this condition might lead to being late in detection of the outbreak. Another consideration is the specificity of information, that we can ensure that the data is truly detect the outbreak. So in conclusion, the threat of communicable disease is a constant reality, and our nation must remain vigilant. So developing and enhancing our early warning system, including exploring and integration of the pharmacy sales data, is a proactive step toward better preparedness and response. So by addressing this challenge and enhancing some innovations, we can strengthen our capacity to detect, to respond, and ultimately prevent outbreaks of infectious disease in Indonesia. Thank you for your attention.
Thank you, Dr. Savitri, for finishing time and also for sharing your experiences and the possible way forwards and the challenges that we have in this very interesting topic of data collection through pharmacies. We next have with us a speaker who needs no introduction. We're very pleased and I'm honored to welcome Emma Paulino, who has worked so much with FIP, and congratulations once again on your award yesterday. Emma continues to be a community pharmacist, owning and is a technical director of a community pharmacy. She is the president of the Portuguese National Association of Pharmacies, ANF, and representing the ANF in various capacities. Please join hands to welcome Emma for this presentation. Thank you.
Thank you very much, Raj, and thank you so much for the kind invitation to present to you today. Dr. Savitri, this was really such a nice presentation to set the stage of what the potential for community pharmacy data is and could be, and you've cited numerous examples of how it is already happening, but in particular, what I'm going to present to you today is a specific example of how we can use that data and how that data can transform the way that healthcare is provided. So I will be talking about HiCore, which is a project that aims to track pharmacy data in Portugal for identifying infectious diseases. So, okay. This project has obviously been developed under the banner of the National Association of Pharmacies, but in terms of the practical aspects of it, has been led by a team whose leader is actually here, António Teixeira, and he was cited actually in the previous presentation, which was awesome. So we will be talking about that work during this presentation today. We have no conflicts of interest to declare. And in terms of just the background of how this work came to fruition and what was the context behind it, we know that OTC medication, so over-the-counter medication and other healthcare products, have already been used for early detection of gastrointestinal and respiratory diseases and to anticipate outbreak detections. So, as was mentioned before, we have some published literature that has shown this potential. We also know that thermometer sales have been used to estimate the incidence of symptomatic similar diseases to influenza. Basically, what we had to do was to select certain OTC pharmaceutical categories that can be used to predict patient volume in an urgent care setting or during an influenza outbreak, and this has also been shown in literature. So what were our methodological key points in terms of the work that was developed? First, a little bit of context in terms of the data and in terms of the sample size. In Portugal, we gather transactional data from all sales from 85% of all pharmacies in Portugal. Of course, this data is provided on an anonymous basis, and this data is routinely collected and analyzed. So we have this large pool of data from where we can draw the information. These pharmacies, obviously the 85% of pharmacies are distributed nationwide and do reflect the population density in each region. So as we will be able to show you, we can also not only show data in terms of the national representation, but we are able also to see what happens at the local level very precisely because of this distribution of data. We thought that the high-core surveillance system would add value to the system, and what we aimed was to anticipate the peak and intensity of outbreaks, particularly referring influenza. And through this, we aim to anticipate the impact in health centers and hospitals at municipality level, which is critical, obviously, for public health authorities, and will be able to inform how our system can and should be prepared to respond in particularly high-intensity periods. So what we do is we collect the sales in community pharmacies, and we collect these through sellout of specific non-prescription medicines. We use data mining procedures, which, as you know, is the process of sorting through large sets of data in order to identify patterns and relationships that can then help us respond to a specific question through data analysis of that specific pool of data. So we identified the OTC basket of products that would allow us to monitor the management of influenza-like illness symptoms. So, for instance, we included medication that aimed to treat, for instance, fever, other types of respiratory tract infection symptoms as well. So, and this has been a dynamic basket because of, obviously, there are products that enter and get out of the market, so we have to continuously update this basket of products that we use for the sales data. And we have also used the epidemiological model, the moving epidemic method, which basically what it does, it looks at the epidemic threshold of pre-epidemic values of historical seasons. So we look to previous seasons, and we set the epidemic threshold to establish what would be the threshold above which we would consider that we are entering a peak or moving towards a peak of that influenza outbreak. So we use surveillance and predicting methods to evaluate the beginning, the length, and the intensity of influenza outbreaks in Portugal. And this is from the flu season, data from the flu season 2018-2019. And basically what we aimed was to establish whether our anticipated goal, which was to predict the outbreaks, whether we could or couldn't do it through the pharmacy sales data. So we wanted to prove our hypothesis in terms of what this data could tell us in anticipation. So I will show you how it went through time. So as you can see, these are weeks in the year, and we can see that in terms of high core, that means the data that we collected in community pharmacies, we saw that in week 49, the basal activity threshold was reached, which could, and if all went well in our thought process in that community pharmacy sales of these OTC medications would predict, then the illness cases really presented in primary care, because that's how we measured it. We measured cases in primary care. Then this would mean that the gray line would accompany the green line through time. And that's exactly what we saw. So the green line continued to increase, so pharmacy sales data continued to increase in terms of these OTC medications that were used to treat respiratory tract infections. And what we saw was really an increase in terms of the primary care consultations on influenza-like infections 2 weeks after. So 15 days after we detected them in community pharmacy. And when we continue, we saw that, for instance, in week 3, what we saw was apparently we reached the peak of the infections, and we would see a decrease from then on, and that's exactly what happened 2 weeks later with people presenting to primary healthcare centers for these kinds of conditions. So what we really concluded from this first season when we started collecting the data and making this analysis was that ICOR, this project, detects the beginning and the peak of the influenza outbreak approximately 2 weeks ahead of the sentinel influenza-like illness surveillance system based on medical consultations in primary healthcare. From then on, we have continued to use this data every flu season, and we have continued to monitor this data. So, as I've mentioned, we are able to collect the data from pharmacy sales at a very local level because of the large number of pharmacies that are part of the panel that are collecting evidence. So we are actually able to signal differences within our national territory. So here you can see, for instance, the influenza activity in the country throughout the flu season, and you can see that some regions are in high intensity whilst others are in low intensity. So we are able to provide this data also to the health authorities so that they not only organize the response at the national level, but they are really able to tailor the response and the teams, both in emergency hospital rooms and also in primary care. They are able to tailor those interventions and are able to tailor operating hours and the number of healthcare professionals that they have to be able to respond to this higher intensity of people presenting with respiratory symptoms, and we are able to do that per municipality. So, as a conclusion of what I already mentioned, ICOR is based on a national network of community pharmacies which improves surveillance at the municipality level. And again, here is the information that I've already shown in terms of ICOR anticipating the trend of reported new confirmed cases of COVID-19 in Portugal also in 2 weeks. So this not only applied to flu, but also we can transfer this knowledge and this method of anticipating infectious outbreaks to other types of virus, namely COVID-19, respiratory virus, using the same set of data. We just have to adapt the basket of products that we use to anticipate the threshold surpassing and the peaks of infectious diseases. So, as I've mentioned, ICOR is able to detect different outbreaks by adjusting the set of OTC products that we have under surveillance. So we basically tested the model. Now we can use the model to also cater to other infectious diseases. One important aspect also of this project was that we early on we established collaboration with the Portuguese National Association of Public Health Physicians, because if we are collecting the data, if we can predict within 2 weeks what will happen in terms of resource utilization, we have to do something with the data and make sure that those that are responsible for organizing the national healthcare system response have access to the data and use the data accordingly. So the Portuguese National Association of Public Health Physicians actually has on their website, during the flu season, they publish the regional pharmacoepidemiological situation. So they have the information in graphs applicable to the different regions in Portugal, so they are able to inform their associates, so the physicians that are responsible for public health in Portugal, about the intensity, the level of intensity of influenza in the the different regions. So this has been a very important collaboration between pharmacists and public health physicians. To conclude, of course, we are talking about real-world data, and every day, as was mentioned before, community pharmacies gather real-world data, thereby generating substantial real-world evidence in the process. As was mentioned before, community pharmacies, through their regular interventions, already collect a lot of data. They collect data not only related to dispensing, but are now collecting data related to interventions as well. Not only the types of services that are provided to the population, but we can also start collecting data about the results of those interventions. And this kind of data can be really important, not only to show and to, because that's the traditional use we've been giving to this data, not only to show the impact of the pharmacist intervention, but also, as we've shown here, we can also help organize the system better in a more efficient way and be able to highlight the role that the pharmacist has, not only in the treatment, but also in terms of health promotion, public health, and really this can show that due to patients presenting to community pharmacy first to have access to non-prescription medicines for respiratory conditions, pharmacies should have and could have tailored interventions to these patients to avoid them having to go to primary care or emergency rooms 2 weeks later. So we can cater to these patients in community pharmacies before they have to resort to other types of and levels of care. So this project, we believe, significantly enhances the foundation for evidence-based health policies, as I've mentioned, and it's really about having the right information to make better decisions. It amplifies the quality of patient care because we anticipate what people need and therefore we are ready when they come. It's not only being reactive to what patients need, but being proactive in terms of what we have to deliver. And it contributes to the enhancement of public health surveillance systems in general. Through this, we believe that we have also shown that there should be a place for pharmacists at the table when public health policies are being discussed and when we are preparing for situations like the flu season or when we are discussing epidemics like COVID-19. And through this, I'm happy to say that community pharmacies in Portugal has continuously been called and invited to be at the table to have informed and joint discussions about what we can do in collaboration. And we believe that there is much more that can be done. We believe that what this cartoon clearly shows that what the system that we've had until today, where clinical data from clinical trials that are, as we know, very well controlled and where the population is very well behaved, do not really reflect what happens in real world when patients are presented with a number of medication that they have to take in different situations, family situations, social situations. And governments are more and more, and governments and insurance companies are more and more looking at what the effectiveness, the real world effectiveness of these health interventions, namely medications, and also the cost effectiveness of these interventions. And this is where we think that pharmacy and community pharmacies specifically have so much more to offer. So thank you very much for your attention. Look forward to the discussion. Thank you.
Thank you very much, Emma. The exquisite presentation and explanation and pitching for the role of the pharmacist in data surveillance, as well as for inclusion in line with the theme for this year's FIP, that pharmacists should be included. Now we are open for questions, and both the speakers, they will be the part of the panel discussion. And we have any volunteers running the mics? Please introduce yourself in one line and ask your question.
Hi, good morning, my panelists. My name is Shan. I'm from Malaysia. I'd like to thank the panelists for the very insightful presentation. I'd like to ask from the Portugal perspective, could you kindly share how did you manage to get all the community pharmacies to share your sales data at the national level? I think that is so impressive. I think if we do that in Malaysia, it will be a major uproar from all the community pharmacies on their data protection. So it would be great to hear from your side. Thank you.
So thank you very much for your question. Well, actually, in Portugal, we have a pretty unique, I would say, situation in which 94% of pharmacies are affiliated to the National Association of Pharmacies, although it's a voluntary association, so they don't have to be members, but they are members. And most of those pharmacies would have a unique software system that is provided by the National Association of Pharmacies. Through that system, we provide that system for free for pharmacies, and we provide other types of services for free, and what pharmacies give back is the data that they collect. So it's a mutual benefit situation in which we provide services to the pharmacies provide the data, and they know what we do with the data. So you have to involve community pharmacists with what you are doing with the data. So we continuously give feedback to the pharmacies, not only in terms of what we do in these epidemiological studies, but we also use the data for advocacy with the government and with other stakeholders, we explain to pharmacies how important the data is for those objectives. And I think that community pharmacy owners in Portugal understand that providing this data to the National Association of Pharmacies is in their favor, because we are able to produce these kind of studies. We are able to advocate better to other stakeholders, but obviously in terms of at the practical level, having the unique software system, well, it's not unique, but the vast majority of pharmacies use this software system. It makes it much easier for us to collect the data. Also, in the National Association of Pharmacies, we have another pool of data related to a loyalty system that we have for the network of pharmacies. It's also voluntary, so not all pharmacies are participating, but those who participate also provide an additional set of data to the National Association of Pharmacies, which we can then use also to understand consumer behavior and why people go to pharmacies, what kind of basket of products they have, and this is fed back to pharmacies as information that they can use to adapt their portfolio of products and services. So I think it's really about giving back to the pharmacies, both in terms of information and in terms of tools that they can use with the data that they believe is an added value for them as well. So I think that, I don't know if I answered the question, but it's about its concept, and it's about how to operationalize.
Yes, hello, my name is Jens Gobrecht from ABDA in Germany. I have a question to Emma as well. I like your project very much because it's relatively simple and has a great impact. My only question would be, how do you define this baseline or threshold line? so that you are not blurred by dispensing numbers that are too high or too low? How do you define that?
You mean in terms of how we pull the data and how we apply the methods?
No, you said when the sales numbers reach a certain line, this threshold line, but how do you define how high this threshold line is?
It's based on previous influenza seasons thresholds. So we establish using that method I've shown. So we know the threshold based on previous seasons that were the pre-epidemic seasons. But maybe Antonio may explain better than I do. Antonio, do you want to explain better? Let's take advantage of the fact that the scientist is here.
Thank you, Emma. I'll try to explain, but yeah, that's what Emma says. So we use the data from the previous 5 years, and then to analyze it to detect when the season starts. And that is given by the model that is also used for the primary care data, which is the moving epidemic method. So it's very simple.
So this means you need a little bit time before until you can apply the system. So 5 years to get a real sound data base to define this baseline. Excellent. Thank you very much.
Just one thing, that we have used this 5 year of data, but we have not used this 5 year of data in all the country. It was only in one region to validate the model and then apply all the model to the whole country.
Thank you, Antonio.
Any other question? Yes.
Hi, Adrian Shepherd from Reckitt. So I'm sure some of our products are in your basket for defining the OTC sales. I just wondered, we know that there's a lot of inappropriate antibiotic use for respiratory conditions. Have you done a correlation also with antibiotic dispensing associated with those peaks in influenza-like illness as well?
We are using OTC sales because that's usually what people present first in the community pharmacy when they start to have symptoms. Antibiotics appear a little bit later on in the patient journey. So antibiotics are already prescribed, so we don't have any pharmacist prescribed antibiotics in Portugal, so that would mean that people had already been to the doctor. And what we want to do is anticipate when people will go to the physician. So we do not include antibiotics in this basket. That's why we only include non-prescription medicines, because we want to anticipate that visit to the physician. But obviously, we can introduce antibiotics in the basket if we want, for instance, to, let's say, if we want to look at primary care, healthcare as a whole, and we want to prevent emergency room visits where we use antibiotics that are usually only dispensed and administered at hospital level. Then we can use the antibiotics we prescribed at the primary care plus the OTCs, and what we are going to predict is the people going to emergency care rooms and having to be treated with other types of antibiotics. I think that now that we have tested the system, is really just a look at what kind of problems we would like to solve or anticipate and choose the right basket of products that we would like to include in the surveillance.
Hi, thank you. I'm Bill Laffey. I'm in the medical team at Reckitt. I really enjoyed the presentation, and I don't know if it's the same in Portugal, but in England, GPs can only prescribe antivirals for influenza once influenza levels are known to be high in the community. Only then can you prescribe. So I think it would be such a useful piece of research to extend to other countries. You mentioned that the baskets that you have were different for influenza compared to COVID, that they were slightly different baskets. I just wonder, do you know what the differences were in the products that people were using for COVID compared to influenza?
Well, it's really about the different symptoms that we know, and actually for COVID-19 that was pretty dynamic because we saw variants at the beginning of the outbreak that were very different in terms of symptoms from those that appeared afterwards. So even in the National Association, we built these very nice comparison tables about symptoms that would differentiate flu from COVID-19, but at some point it began very difficult to update because we saw so many different symptoms evolving with COVID-19. But with COVID-19, we certainly had more analgesics and pretty less products, for instance, for nose situations. I'm not sure how to really present this in English. Yeah, but there were different types of products, but some of them were common, but some of them were particular. And it depended on the symptoms, and obviously like I said, we have to update them throughout time of what we know that specific variant of the virus is most known for providing in terms of symptoms.
Thank you so much.
I'm also curious to ask. I would like to ask both of you. You have said that this could be extended to other illnesses. Could you give examples of one or two, or something which is in your pipeline that you would like to do next or include it in your basket?
Thank you.
Well, let me see if I can remember some. Well, this can be applicable to different infectious diseases or different types of symptoms. We obviously saw, after we developed this for flu, we obviously saw the application for COVID-19, but we can also track other types of infectious diseases, and we had, for instance, the Mpox situation. So all types of public health emergencies in terms of virus can be, we can use this system to track. So we don't have anything specific in our pipeline now, but we aim to make this system more robust. And for Portugal, these two situations seem to be the most important at the moment for us to track, both flu, influenza and COVID-19.
I think we have also an example in our country. So, for example, when particularly it is in Bali province, so when there are mountain eruption, so people getting cough and have, disease with related to respiratory infection. So the sales in pharmacy medication is also increased. So it's really depend on what we want to detect. Yeah, so that is why in our presentation, we said that to develop the system, we need to discuss it with the expert for clinicians, and also the expert for the system, for example, for the applications. Yeah, that's all. Thank you.
Thank you. I think with time, people will think of different infections to detect. Yes, please. Yes.
Thank you, Chair. Sham Mudli from the FIP CPS Exco.
Excuse me, just a minute. Emma has something.
I was only going to say that we can also think about other applications other than infectious diseases. So, for instance, if you have an increased level of allergens in the environment that can anticipate asthma attacks, for instance. And you can identify what people would seek at a pharmacy earlier on for those types of outcomes. So you can also use not only for infectious diseases, but you could also look at complications, acute complications for chronic diseases as well.
Thank you. Yes.
Thank you. Shyam Mudli from the FIP CPS Exco and community pharmacists in South Africa. This has certainly opened new doors for us in South Africa, the two presentations, so well done there. The question to Emma, in terms of influencing government policy in Portugal, the data obviously reflects that pharmacy has the data, is able to predict. Can you influence them in terms of, say, providing the influenza vaccine at community pharmacy level? Has that been done, and are you providing the vaccine? Thank you.
Yes, so I'm happy to say that this year for the flu season, pharmacies will be delivering all vaccinations for flu and COVID-19 for all patients over 60. And without any question, this road that we've done in terms of these types of projects have helped us, like I've mentioned, to be at the table, to present ourselves as healthcare professionals who are part of a public health team that have access to the population in a very timely and professional manner. And I think that what we are having now in terms of recognition from the government, I've mentioned the example, we are immunizing this year for the whole population above 60 will be immunized in community pharmacies. But for instance, last year we also participated in COVID-19 testing. Well, the previous 2 years we also participated in COVID-19 testing for the whole community, also reimbursed by the national healthcare system. And I do think that these are the kind of projects that have risen us to and they've placed us in a good position to be able to be at the table when we are discussing these issues, because we have the data and we have solutions for most of the challenges. So yeah, I really think that what we are getting now as a result is a result of this kind of positioning and this kind of data gathering and studying the data and producing evidence from the information that we get.
Yes, I also had a quick question. I'm not sure about Portugal, but in many countries, OTC medicines are general sales and available in stores other than pharmacies. What challenges would that pose to data collection?
That's a very good question. In Portugal, we also have general sales lists. So we have a pretty wide range of non-prescription products that are sold outside pharmacies, and for those we don't have the data. What we have in Portugal is that around 80%, above 80% of sales of these products are still in community pharmacies. So we still have a very good representation in terms of sales of these products. We also have what we call a third list, which is pharmacy only. So we have some medications who are non-prescription but can only be dispensed in community pharmacies based on a protocol implemented by community pharmacists, and some of those are also included, for instance, in this basket. These would be higher doses of ibuprofen, for instance, or other types of medication used for corticosteroids, nasal corticosteroids, etc. So these would only be in pharmacies. But yes, I think that because we still have a large representation of the sales of non-prescription medicines, we believe that the data the set of data that we use to then do the analysis is quite strong.
Any other questions? Yes, she's coming to you.
Hi, I'm Kim, the infectious diseases pharmacist here at Royal Brisbane Hospital. Thank you both for two very excellent presentations. Emma, this question's for you. In terms of deciding on the products in the basket, can I just ask, who was involved in the decision for that? So who was at the table? Who did you collaborate with in deciding the products in relation to the infectious diseases? Did you have pharmacists? Did you have medical officers? Did you have infectious diseases physicians? Who came up with the choices? Thank you.
Maybe I can ask Antonio to reply.
Thank you, Emma, again. Well, what we did to select the OTC products, we have used the data from previous 5 seasons, and what we have made was, well, we have some clinical criteria, but apart from that, we have also made correlations between the sales of these products and the cases of influenza-like illness in primary care units in Portugal. That's how we used it. We excluded prescription products because we want to identify patients before going to the primary care units. That's what we did. And in the end, we have a basket that we believe was able to predict and anticipate the season, the flu season.
Hi, this is Sam from the United States, New York Presbyterian Hospital in New York. I'm a pharmacy scientist. I'm interested to see, I wonder if in your data set you have seen any kind of surge in purchasing in terms of like panic buying. And I wonder if that also aligns with your data, in real-time data in terms of symptoms surging or disease surging.
Sorry, could you repeat? It has an echo here, so it's not always clear. I'm sorry.
Yes, so I'm just wondering if you have seen in some kind of panic buying behavior in patients in community level, and if you have seen that, does that also aligns with how the infectious disease is spreading in the community?
What kind of behavior? I'm sorry.
Panic buying. Like when people are hearing news that they are surging in terms of disease, they are buying more and more. I'm just wondering if you have seen certain behaviors that aligns with that.
Yes, well, we definitely saw that in COVID-19, where we had a surge of people buying paracetamol without having the need for it, but just anticipating that they would need it in the near future. And obviously, that doesn't help with analyzing the data, but because we really want to gather information from medication that people are already seeking for symptoms that they are already presenting. So when we identify that something like that is happening, you have to exclude that from the data. Otherwise, it will mask your results or bias your, I think is a better word, is going to make a bias on your results. But we are able to track that because when that happens, it's due to some kind of communication. particularly communication coming out in journals or either in social media or TV or radio. And we are able to identify when people are being influenced to buy something just for the sake of having it in their medicines cabinet, and we can exclude that data from the analysis and not let it introduce a bias on the analysis. Yeah.
Hi, my name is Raymond. Just a quick question regarding the data you're collecting. I know you collect it for and store it for more than 5 years. I'm curious to know what exactly you're collecting besides the OTC medications. Are there names, gender, age, that sort of thing as well? What assurances do you have in place to prevent any sort of data breach from third parties that potentially want to manipulate that or get into that data?
So, yes, so the data, we do not collect any data pertaining to the patients. So it's only sales data, and it's not allocated to a certain patient. So we don't even, it's not that we anonymize the data. The data isn't even sent to us at the central level. Apart from that, but obviously, for instance, I mentioned about the set of data that we have for the loyalty program. For all of those, when pharmacies do collect the data, apart from having obviously the informed consent form and collecting all the necessary signatures and authorizations from the patients, we have a very strong security system for our database to ensure that we are not attacked in terms of identification of data. And the informed consent is also very clear to people that the data that is being collected may be used for these kind of studies, but will not be used for commercial uses and will not be provided to third-party companies by us. So yeah, we have a whole process when we do collect patient data. It's all anonymized and it's all kept in a very tight database. But in terms of this project in particular, we are only collecting the sales data. It's only sales. We don't relate it to an individual.
Yeah, my question to panel. I'm Jaguste from Community Pharmacies India. See, you must have captured data from the country, okay? But what about the cross-border sale of antibiotic? Have you ever, any panel have captured the data selling medicines on internet, indiscriminate, and they're violating the rules of the countries? So like any country, they have their rules and their regulations to control the menace of antibiotic misuse. But there is no control on the sale of medicines over the border, cross borders. So any agency capturing that data, what the menace that they have developed by selling these medicines or antibiotic cross border? Thank you.
Yes, thank you very much for your question. I really agree with you that we have to have regulations in place that ensure that what patients are receiving is a good assessment prior to the prescription of an antibiotic, and that when they do access an antibiotic, that it's a quality medicine and it's a quality medicine. In Portugal, in particular, we have regulations that do not allow for online pharmacies to exist. So we have online dispensing, but that can only occur through a physical, through an existing physical pharmacy. So pharmacies, each pharmacy may have their own website where they dispense medication online, but they still have the responsibility to interact with the patient, and those online websites have to be correlated, have to be linked to a physical community pharmacy to ensure responsible dispensing and to ensure that there are interactions with the patient, both in terms of ensuring that there is a valid prescription for the medication and in terms of dispensing the medication with the right counseling and with the right information for the medicine to be used in a rational way. So that's the regulation in Portugal, and I think that it is a good legislation in that it ensures that there is that interaction and that there is that specific point of care that the patient can refer to if he has any questions, even that arise after the medicine is dispensed.
Hello, Emma. Here in the end of the, okay. Fazlullah here from Malaysia. Thank you for your wonderful study and presentation. The value of such a study is about the predictive measures that we can do later, actually. My question is, okay, if you collect the data first, and then later you analyze the data, for example, trend analysis, for example, or time series studies or something like that, to predict the future epidemic, for example, or something like that. It takes time, actually, no? So the predictive value may be victimized because of what? Because of the delayed analysis. So it would be valuable only if real-time analysis is there, for example. Once we see the elevation of the OTC medication, for example, then we can say, okay, the epidemic is coming, for example. How did you settle the issue, for example? How did you run the real-time analysis? You know, how did you settle this you know, quick kind of analysis on the collected data, for example? Thank you.
Thank you so much for your question, and this is so relevant, and now I feel that I haven't really mentioned it during the presentation. This data is really collected in real time. So we get the sales data on a daily basis from pharmacies, and the algorithm runs through the set of data in real time. So we are able to produce real-time information from this, and this is how we manage to anticipate, because like you said, if we do this retrospectively, it would be interesting, but it wouldn't add value in terms of what we really want to do, which is prepare ourselves for an increased pharmacy visits or increased medical visits. So we do this in real time. We collect the data from pharmacies on a daily basis. The algorithm runs in the set of data, and we publish every week. I think it's is it Antonio? In terms of the data we send, is it weekly? Yeah. Yeah, we publish the weekly bulletin, but the data is always running, so we are able to see whether there's where the surge is happening or not, and we are able to anticipate that in real time.
Thank you so much. We have just run out of time. Thank you so much for the wonderful audience with your interesting questions and keeping the conversation and the topic alive. And thank you equally to the two speakers, Dr. Savitri and Emma, for introducing such an interesting and lively topic. And I'm sure in the coming years, more and more countries will look at this aspect, and so many challenges are there. And I think only when we move forward with time and experiment with these things, we will be able to produce even more data and even more importance of community pharmacists. Thank you, everyone, once again.